This is Joe Schrader, firefighter paramedic with the Vancouver Fire Department. Today I'm going to be teaching a trauma overview as well as some changes that we've made to our trauma kit and our triage bag. Just an overview of the course, we're going to be talking about some evidence-based medicine, TECC guidelines, phases of care, the March principles, assessment and interventions, specific injuries, and then the changes to both kits. Just a background on where this all came from. With cardiac care, it's all driven by evidence-based medicine. That's something that we hear often. And the driving force of that is ACLS. And anytime something changes in the industry with science, it quickly works its way into the field, and so we're often making changes to our CPR guidelines and such. With trauma, PHTLS is the driving force, and although the changes don't happen quite as fast as with ACLS, and there's an arm to PHTLS, which is tactical combat casualty care, and that's what the military uses for trauma care. They're treating mainly penetrating injuries on the battlefield. And there's a lot of evidence-based medicine coming out of there, but it's not working its way to the civilian pre-hospital setting very fast. There's two distinct phases of care in pre-hospital medicine. There's the on-scene phase, which is initial arriving units do the life-saving interventions, basically stabilizing the ABCs, and then immobilizing and packaging the patient. Our goal is 10 minutes on scene. And then there's the transport phase. That's where we're going to stabilize the patient further, start IVs. If we need to establish definitive airway, that's the time to do it. And then pain management and splinting and reassessing the patient. For pre-hospital trauma care, it really can be looked at as pre-surgical care. What can we do in the pre-hospital setting before the patient gets to the hospital to give them the best chance of survival, surviving first surgery and that stabilization, and then their recovery. The overall goal really is to save red blood cells. And that's going to help us to oxygenate the patient and prevent shock. So any and all bleeding should be controlled in these patients, external bleeding, because whether it's arterial or venous blood, it's still blood, and we need to save every red blood cell. So in a sense, the focus is really on BLS level skills, especially in that on-scene phase. Tactical emergency casualty care is a version of tactical combat casualty care. And it's sort of the civilian version that there were some slight changes made for law enforcement, mainly SWAT teams that were a little more applicable for the civilian environment. And there's really three identified preventable battlefield deaths that the military identified looking back at several different conflicts and the casualties. 85% of those preventable battlefield deaths were hemorrhage. 50% was extremity hemorrhages, and that's where the emphasis on tourniquet use really came out of. 10% was tension pneumothorax, and then 1% was airway injuries. There's three phases of care in TECC. There's care under fire or direct threat care. That's where in the combat environment you're taking effective fire from a threat and you're performing self-aid or buddy aid or directing that type of aid for someone else. And really you can't perform any more treatments until you can get away from that threat. This isn't really applicable, obviously, for fire-based EMS, hopefully. The second phase is tactical field care. That's the on-scene phase, that 10 minutes that we arrive on scene. And for fire-based, non-transporting EMS, that's really where our emphasis should be, is on that on-scene phase, stabilizing that patient and preparing them for transport. And then the third phase is the evacuation care transport phase. So that would be obviously transporting the patient in the ambulance to the hospital. The March Principles is an acronym or just guideline for the assessment and treatment of traumatic injuries. It's kind of the ABCs of trauma, really. And although it was put together mainly for penetrating trauma, it really can work for any trauma assessment. That initial assessment of the patient, it really guides what interventions can be done on scene, whether this is a penetrating trauma, somebody that's been shot, or it's a car accident or an elderly fall victim that was found in their bathroom. This assessment really is going to identify those treatable injuries that need to be managed on scene. So the M stands for massive bleeding. This is going to be the exsanguinating hemorrhage that we can see walking up to the patient or find quickly. There's going to be an arterial bleed, and again, one of our main priorities is to save red blood cells. So when you are faced with massive bleeding, tourniquet is the most appropriate management of that. And the emphasis of tourniquets has really, over the last decade, really come to the forefront, whereas it used to be considered a very last-ditch effort. If all else had failed, then you would go to the tourniquet. By that time, your patient has already bled out. So considering life over limb, tourniquets should really be used as the first-line management of these significant bleeds. For injuries that you can't apply a tourniquet to because it's a junctional wound, not on the extremities rather, there's wound packing, and that's mainly for junctional wounds. We'll talk about that a little bit later in this class, and there will be a skills presentation for that. The A stands for airway in March. It's going to be the assessment and management of the airway. Initially, the best adjuncts for that is the NPA or OPA if the patient doesn't have a gag reflex. You can also consider the iGel. These are quick things that we can do on scene. They don't take much time, and it can be done by one person in a few seconds just to open up that airway temporarily. And then the definitive airways would be the endotracheal tube. If none of these are effective, then we go to the surgical airway. The R is for respirations. It's going to be injuries to the chest or ineffective breathing, basically. So with the assessment of the chest, we're going to look for penetrating chest injuries, and we want to seal all those holes with a chest seal. And then if we suspect attention pneumothorax, then we go right to needle decompression of that side. And then BVM assist for the patient that's not ventilating adequately on their own. The C is circulation. That's going to be where we identify all bleeding, not just the massive bleeding. And we're going to bandage those injuries with a compression bandage or the normal means. Abdominal seals for abdominal injuries, covering eye injuries, and then the initial treatment of burns. The H stands for head and hypothermia. So for head, it's going to be assessing the AVPU and GCS of the patient. And then for hypothermia, the key to treating hypothermia is really preventing it from happening. So you really have to start early. And hypothermia is a major contributor to mortality in trauma patients. And once it gets started, then it's really difficult to catch up, especially in the patient that's not perfusing well because of trauma. So we really have to be on top of that, and that really should start on scene. And then Another thing that you can add to this is splinting. You could even change the acronym to MARCHES, but the standard is MARCH. So splinting is another consideration on scene, though. That includes cervical spinal immobilization and applying a pelvic sling if you suspect a pelvic injury, and then extremity splinting. So breaking these down, with massive bleeding, we're going to identify this with a rapid head-to-toe blood sweep. This isn't a detailed trauma exam, head-to-toe trauma exam. We're just sweeping the body looking for massive bleeding. When we find it, we stop and we treat it. If it's an extremity, we apply a tourniquet. If it's anywhere else on the body, we can consider wound packing or a compression bandage or direct pressure. The normal means direct pressure, pressure points, pressure dressing, and then the tourniquet and wound packing. There's real emphasis on addressing the bleeding at its source, not just the hole. We're not just going to cover a hole with gauze that we see blood coming out of. We really want to address it at that source of bleeding, the vessel that's bleeding. You know, that source has a name, and we need to address it at that source, whether it's an artery or a vein. We need to get in there and control it. Applying tourniquets, there's a few different techniques or types of tourniquets. In the Vancouver Fire Department, we carry the CAT, or the Combat Application Tourniquet, but there are many different tourniquets on the market. A hasty tourniquet is basically applying the tourniquet as high as you can and as tight as you can on the extremity, whether it's an amputated hand or arterial bleed in the lower or upper arm. We're still going to apply the tourniquet high on the extremity. The benefits of this is the artery is largest in the upper extremity, it's close to the surface, and it's running along one bone. So it's much easier to tamponade. In the lower extremity, you have multiple arteries, they're deeper and covered by tissue, and there's two bones in the lower arm and leg. And there's a lot of evidence that shows that a tourniquet that's placed for 2 hours or less has little to no chance of causing any tissue or vascular damage to the extremity. You're going to place and secure the tourniquet, removing all slack out of the tourniquet strap before tightening the tourniquet down. And then you're going to turn the windlass bar until it cannot be turned anymore, or until the bleeding stops. And then you're going to secure the tourniquet in place. With legs, a significant bleed, arterial bleed in the leg, often requires more than one tourniquet. And in that case, if the first tourniquet isn't adequate in controlling bleeding, then the second tourniquet will be applied directly below the first one, essentially making a larger, wider tourniquet. It's going to cover more surface area. Tourniquets are very painful. And so with a patient that is even semi-conscious, you're going to need to plan for pain management, or the patient's going to be trying to remove that tourniquet. For wound packing, this is directional pressure. We're packing wounds that are junctional wounds too high in the axillary or inguinal area on the upper arm or legs. It's too high to apply a tourniquet, and so we need other means to control the bleeding at its source. With wound packing, we have gauze that's made. It's basically just unrolled Kerlix that is in a bag, and you can stuff it into the wound. We'll have a video later to show that technique. And then once that gauze is placed in the wound, then we hold pressure, very, very heavy pressure against that gauze for a minimum of 3 minutes, no peeking. This gauze is not impregnated with a hemostatic agent like some combat dressings are. Here in Vancouver, we use just a standard Kerlix gauze. Once the bleeding is controlled, then we're going to put a compression bandage over that gauze that's been placed in the wound. The trunk of the body is considered a compartment, the chest and thoracic cavity, the abdomen. We don't want to blindly pack those wounds with gauze, because you're potentially just packing gauze into the chest cavity or abdomen, and for obvious reasons that's not a good idea. However, if you do have an arterial bleed in an open wound in the chest, and that artery seems to be in the chest wall, you can attempt to pack that wound and control the bleeding. In that case, you're packing against other structures, and so you're going to be able to control that bleeding. For airway, initially we're going to clear the airway of any obstructions. That could be teeth, blood, chew, any foreign bodies. And then we're going to protect that airway. We want to keep it open. So the progression of airway control is to evaluate the airway, open and clear it, and then protect it. And our options for manually protecting the airway are beyond head tilt, chin lift, or the modified jaw thrust, or the NPA, the OPA, or the iGel, and then endotracheal tube and surgical crike. If you're thinking you need to do a surgical crike, then you should probably do it. The thing that takes the longest with doing a surgical crike is just making that decision that you actually need to do it. So if it's in your mind, then you should probably be doing it. With any airway control, plan for failure. Always have a backup plan. What are you going to do if the intervention you're attempting doesn't work? Once you've controlled the airway, you want to improve oxygenation with ventilation, and then perform your procedures. For respirations, we're going to assess the rate, quality, and depth of ventilation. Cover any holes that you find. That includes the neck and the upper chest, and then also upper abdomen, because if there's penetrating trauma, you don't know the path that hole is going. It can be going into the thoracic cavity and leading to a tension pneumothorax. So cover the holes and then support ventilations. The chest seal options that you have are the Asherman chest seal, which is a vented seal. It has an adhesive backing, and then in the middle of it there's a one-way flutter valve. Essentially, that's placed over the wound and allows air to escape from the chest out that vent. The other option is an unvented seal, and one of the best chest seals that we have available to us is the defib pad. It's made to stick to hairy, sweaty, bloody skin, and has that gel that does really well. So it also covers a large surface area. We carry them in all of our monitors. If you have an expired chest or expired defib pad, rather than throwing it away, you can put it in your trauma kit along with your Asherman chest seal and have that as a second option. And an option that you can do is place that seal, just cut the cable off, and then draw an X on the pad, and that'll help the hospital staff to not be confused that there's defib pads on a trauma patient. Always check for an exit wound. If you have a gunshot or penetrating wound to the chest, always check the back, and then also the axillary area underneath the armpit. Oftentimes you can miss small gunshot wounds, penetrating trauma in that area. And then anytime you consider that the patient may have a tension pneumothorax, then we should be doing a needle decompression. PHTLS standards no longer recommend a one-way flutter valve. You don't need to put on a three-way stopcock or a flutter valve or anything else. That you're essentially converting that tension pneumothorax to a simple pneumothorax by placing the decompression needle. There's also some studies that have shown and experienced that for people that have done a few chest decompressions, this is really a temporary intervention for a tension pneumothorax. The catheter that we use is a 14 gauge needle. It's a pretty small opening, and that hole can become obstructed by blood or tissue once it's placed. So it really is just going to initially decompress that pleural space. But definitively, this patient needs a chest tube once they get to the hospital. In Clark County, the standard is for a chest decompression is in the second intercostal space, mid-clavicular line. Remember to always go over the rib underneath